Right. Let me start by welcoming our speakers, our guests who have joined here today for the 9th webinar of Evidence-Based Action and Policy Roundtables. As you know that perhaps the most pressing matter than pressing development question that we have been seeing since the last 3 years has been that of health and well-being. And as the pandemic has hit, it has exposed how vulnerable we are in the face of an epidemiological crisis. India's villages have been facing double health challenges at this time. First, the challenge of and the threat of contracting COVID-19, of course, and the second challenge is the deepening health inequality and losing the gains of public health outcomes of the past decades. Along with the inequity of health, the pandemic has also reinforced the need to focus on specific population cohorts as the health risks of children, adolescents, youth, and aged are very distinctive. In this backdrop, we have called this webinar today to discuss what should be India's comprehensive rural health policy, to have a vision of how the rural health policy should be shaped. And there are multiple issues, of course, but it's a limited panel where we will focus on some of these issues that we can discuss today. And the panel prides itself with 3 leading health experts globally. First, we have Dr. Arun Balachandran from University of Maryland, USA. Second, we have Dr. Apurv Soni from University of Massachusetts Chan Medical School, US. And finally, we have Dr. Sonu Bhaskar, CEO, Director, Global Health Neurology Lab, Sydney, and Founding Director of NSW Brain Clot Bank, NSW Health Pathology, Sydney, from Australia. He'll be sharing the global solutions to India's rural health access inequality. Now, before I introduce each of the speakers and what they'll be talking about, I would like to invite our head of the School of Public Policy and Good Governance, Professor Jyoti Satyapalan, to formally open the program and welcome our guests. Sir, it's over to you.
Thank you, Dr. Ruchira. I'm really happy to see that you are organizing an important webinar. It's focusing on what should be India's comprehensive rural development policy. The focus on SDG 3 is quite important, and we are, it's going through the major crisis of health these last 2-3 years, and I feel really that it's a very important contribution to the policy makers and also to the academic world. On behalf of NARD-PR and the DG NARD-PR, I welcome all of you, the distinguished participants and the distinguished scholars, international scholars who are present here. Dr. Arun Balachandran is from University of Maryland. We are really happy to have you with this webinar. And also Apurv Soni. Dr. Apurv Soni is from UMass Chan Medical School. And also Dr. Sonu Bhaskar from the NSW Health Pathology, Sydney. We are really happy to have you in this webinar. On behalf of the NARD-PR, I welcome all of you to this. I request to the coordinators, Ruchira Bhattacharya and Partha Sahu, to coordinate the proceedings of this program. Thank you.
Thank you, Professor Satyapalan.
You may
yeah, I will take it up from here. I just had a call from the Office Director General. Unfortunately, he's caught up in another meeting. He's not able to join. So we will continue with the program as it is. So let us first invite our first speaker, our young public health expert, Dr. Arun Balachandran. He's a PhD in demography from the University of Groningen, Netherlands. He did his pre-doctoral training at the Institute of Social and Economic Change, India, and has a background of discipline of economics. He worked towards population aging in Europe and Asia and developed new measures of population aging for comparisons across Europe and Asia, with a particular focus on gender. He has been widely published in Aging and Society, Journal of Aging and Health, SSM Population Health, Economic and Political Weekly, and The Lancet. Arun received the KB Pathak Memorial Award 2019 for Methodological Innovation in Population and Health by Indian Association for the Study of Population. He has been working with Population Council earlier, but now he is working on the WEDGE project that evaluates measures of gender empowerment with a global focus, and the India Human Development Survey, which develops, administers, and analyzes different measures of social and gender empowerment. Welcome, Arun. I hope you can share your screen and start presenting. And please unmute yourself and over to you.
See my screen. I'll find my screen. Okay, I hope now we can see my screen.
Yes, Arun, just one request. Can you bring the mic a little closer so that we can hear you a little more clearly?
Sure.
Yeah. Thank you so
Okay.
much.
Yeah. All right. Excuse my, my newness to the Google Meet. But thanks a lot, Dr. Ruchira and Dr. Jyoti Satyabalan for the introductions. And uh, uh, I really thank the National Institute for Rural Development and Panchayati Raj for this opportunity. Uh, Yes, as Ruchira and Dr. Jyotis has been mentioning, age population who has been one of those most vulnerable sections, during the COVID pandemic. My own work has been mostly on age population across the globe, but in this talk, I would like to bring out some ideas from my methodological conceptual framework of population aging to understand population aging in India, and particularly in rural India. Okay. So I have titled this as population aging in rural India and why should it matter. And I'm sure all of you are aware of this background, but mostly the demographic debates in India before COVID has been around the demographic dividend, and population aging was often assumed to be an issue that's affecting the urban India or the southern state. In the 1970s, we had these discussions around family planning, fertility, etc. Uh, and even before that, and throughout the independent years, we have been discussing about mortality related issues. But what has happened over time is that both our fertility and mortality had moved on to a transition. Both of them, both fertility and mortality had actually declined over time. Fertility from around 5.1 in 1970 to around 2.1 in 21, and similarly about a mortality decline with a life expectancy at birth increase from 47 in 1970 to 69 in 2019. So a natural consequence of this is that the share of population at our higher end of our age pyramid, or the share of population of upper ages will increase, which we call as a share of elderly. And thus a natural consequence of this demographic transition is that we have an increase in the trends of population aging. According to recent statistics, there has been an increase in share of elderly in India from 5.5 in 1950s to around 10.1 in the 2020, and this is kind of similar in rural and urban areas, as it's 8.8%, and in terms of share, it's very similar, like 8.8% versus 8.1%. But in terms of absolute number, these numbers are
Sir, no
various.
change in PV presentation.
Yeah, can you hear you? Can you hear me? Ruchita, can you hear me?
Yes, you're audible, Arun. I think your presentation is not visible.
Oh.
If you share the full screen instead of just the presentation, maybe we'll be able to see it clear.
Can you see that now?
Have you shared your screen, Arun? Because you can't see the.
Can you see that now? No. Yes, I can see it on my screen.
If you go to the presentation, the Google Meet and share your screen.
Yeah.
Right. All right. You can see the file now if you start presenting. Yeah, right. Perfect. You can see.
Okay. All right. Okay. I'm sorry that you couldn't see that earlier. So that was my first slide. Why population aging in rural India and why should it matter? And these were the population, background. This was the background that I was mentioning about on different demographic trends. And as I was mentioning, if you look at the share of elderly, it's the difference is 8.8% in rural India and 8.1% in urban India. But in absolute number, this translates to a bigger number, which clearly because in rural India the populations are larger, so it's around 3 times more than the urban 60 plus lives in the rural India. Now this is a typical graph of a population pyramid, a very basic graph for any demographic student of demography. And on the left, what we see is the population pyramid of India in the 1950s. On the middle is the population pyramid in 2015, and on the right is that at 2050. So what we see is the skewing of the bottom of this pyramid, which means that the population at younger ages, as they have been decreasing as a share of total population, whereas the population at higher ages are continuously increasing. And how we have been measuring this is this with a single line or a uniform a homogeneous measure, which is the share of elderly or the old age dependency ratio. These are the kind of measures that we normally use to define population aging. And one of the aims of this this talk is also is that I challenge this homogeneous measure across time, across space, etc. And why has been population, while we talk about population aging and its rise, why is often it talked in terms of as a concern? Though decrease in fertility and decrease in mortality, which are both favorable health outcomes, quote unquote, as per health experts, but the result of that, which is an increase in elderly or increase in population aging, is often used as a term of often termed as burden, or the terminologies that are often used in literature is old age dependency ratio or the share of dependence, etc. The chief reasons being that there could be rise in healthcare expenditures because of this, say out-of-pocket expenditure of households or households with higher disabilities of elderly, or the challenges with living arrangements because the younger population of traditionally form support to old age, or there is this macroeconomic governmental level concerns about more health related expenditure, health insurance related expenditure, or pension related expenditure. So while both these factors that has led to this demographic change is seen from seen as favorable health outcomes, the other side of it, which is the rise of elderly, is often seen as a burden, and this is also seen as an issue that are mostly affecting the demographically advanced states in, say, southern India or Himachal Pradesh or Punjab. Let me also put this is my last slide about the background, but there is also urban-rural differential in the factors that led to this demographic change, which is the population aging. So here we can see that there's a rural-urban differential in life expectancy, which we are all aware of. That is, the rural India has normally a lower life expectancy at birth compared to their urban counterparts. On your left, what you see is the difference in urban-rural life expectancy at birth, and on the right is the urban-rural life expectancy at age 60. So if you don't know what that is, you can just like we have the life expectancy at birth, we can find the life expectancy at each age across the life course. And if you look at the difference in urban-rural life expectancy at higher ages, there also we can find that the urban India often has an advantage, which means they have a higher life expectancy at birth as well as at higher ages. On the left, we can see that somebody born in urban India has a life expectancy of almost 5 years higher than somebody born in rural India. So in that context, I want to place this question. That is, if the life expectancy is different at every age, if the remaining years of life is different at every age, does being old or being age 60 mean same across populations, across states? I want to give few illustrations to depict the statement that I mentioned. Say Rajasthan. In Rajasthan, the rural life expectancy at age 60 is around 3 years longer than their urban life expectancy. A person living in rural Rajasthan can expect to live only a person age 60 in rural Rajasthan can expect to live only 3 years lesser than a person in urban Rajasthan. So can we consider them as unique, or can we say both of them as homogeneously old? Another illustration for this is, take example of somebody in Andhra Pradesh. Take a rural female life expectancy, a rural female in Andhra Pradesh at age 60, and she is expected to live 5 more years than her rural female counterpart in Chhattisgarh. So if at age 60 she can expect to live 5 more years than her counterpart in rural Chhattisgarh, can we say that the rural person in Andhra at age 60 is the same as the rural person in rural female in Chhattisgarh? So the point here in both these statements is that, can we say that somebody in a particular state in India living in rural area who is older, who is elderly as well as living in rural areas, similar to somebody who living in their urban side of the state? Or similarly, can we say that somebody living in a particular rural area in a particular state is similar to somebody in another rural part of this country? The argument here is that, what does it mean that you have 5 more or 4 more, 3 more years to live longer than somebody? It also means increases in life expectancy really cannot be separated from improvements in healthcare utilization or social development. So these are improvements in life expectancy is kind of an outcome variable which are often associated with improvements in healthcare utilization, etc. And during the pandemic, we saw literature which actually showed that the rural urban life expectancy has actually widened during the pandemic. So that also means that it's going to be more different for the rural and urban counterpart, rural elderly across states in India. And that's where I want to bring this idea that I worked on during my PhD about this concept of age, which is that, does old age or age mean same across spaces and across populations? And in India itself, we can see that over time life expectancy at birth has increased. To give you a statistic, it's if somebody born in India today can actually expect to live almost double than somebody who was born in 1950, when we in the initial years of our independence. Another way to put this is, in 1950, at age 55, Indian population had 15 more expected years of life, whereas in 2015, 15 more expected years of life for somebody aged 55, and in 2015 for somebody aged 65, there was around 15 more years of expected years. So maybe we can reframe it and blandly put it as, is age 65 in India the new 55? Okay, and this is where I want to start my discussion with. But we in our country there has not been much discussions about elderly, and as well as new and different ways to look at measurement of elderly and elderly welfare. So this idea of having new measures of elderly that we developed is actually based on these new discussions that are happening in Europe, etc., from 2005 onwards, about particularly based in Vienna by this author Sanderson and Cherbow, where they define about something called as prospective age approach, and their argument is that a person can simultaneously have two ages, which is one is their chronological age and two is their prospective age. So chronological age refers to the traditional way of understanding, a retrospective way, which is the number of years lived, whereas the prospective age is looking at number of years to be lived, number of birthdays that a person are expected to have, and so if you look at and their argument, and then they continue their methodology and they argue that if you a new way to look at population aging would be probably to look at aging or old age threshold as the age where the remaining life expectancy is 15. So if you calculate the age at which remaining life expectancy is 15, that would be called as a better prospective way of looking, because you have 15 more years to live from that point, rather than the number of years that you already lived and reaching 60. So this idea basically comes from this idea from economics that we normally have the current prices and the adjusted prices, which is the real prices. We all know that current prices, the nominal prices and real prices are different. So similarly, the nominal age as well as the adjusted or the real age are different across people. And to define the real age, they got this idea of prospective age. Now we improve on this methodology and we argue that why are you using this remaining life expectancy 15 or several ideas, etc. is because you have this vision that's based on the advanced countries, whereas the idea should actually be much more global, in the sense that this is a question of adjusting it across spaces as well, not just across time. So what I mean is, continuing this example from economics, the value of 1 rupee is not the same as value of $1. And what we do in turn is to take one benchmark currency, which is dollar or often, and to compare every currency in the world across, against one currency, right? So, a dollar is so many euros, or so a dollar is so many rupees, etc. So similarly, old age does not mean the same across populations, across spaces, and so we can adjust, say, adult survival probabilities and basically find out ages of, using a standard population, just like the US dollar, being a standard. So you take a standard population and then compare all the populations across spaces against that standard population to find out what is the real age across spaces. Now, the advantages of this is that we see old age. We accommodate improvements in life expectancy into old age threshold calculation. Old age threshold is not a static one; it's a dynamic one rather. And we understand old age from a life course perspective, because based on several aspects in several health vulnerabilities that you faced in across your life course is what your old age life expectancy is defined. Old age remaining life years is found out to be, and then it recognizes that old age is actually different across populations, and in fact it even sees old age as a new beginning of life, because it's the remaining years from there, right? So it's you can also say that it's less ageist, because it sees aging as a beginning of certain phase of life, and it's a new way of population aging, and it supplements our existing understanding using the traditional ways of understanding population aging. Now, I want to give an example of this for our country, India, and then look at this. So here we have over time, and then old age threshold in 1978 was 60, and prospective old age threshold, which is the number of years being remaining years being 15, the expected number of remaining years being 15, is also 60. Whereas the prospective old age threshold increased over time, whereas the traditional old age threshold has been static over time. All right. So this is an example of how of using prospective old age threshold to understand population aging in India. Now, I want to focus on the methodology that we developed, which is a counterfactual to this. That is, take a standard population. So I'm trying to do here an Indian example, and so I'm taking Kerala female population as a standard population, and I want to compare the life expectancies of different states against the that of the standard population. So if uh, if the females in Kerala had a particular life expectancy at age 65, what is the age at which other states in India had the same remaining life expectancy? Okay, so we can see that states like Chhattisgarh and Bihar actually reaches old age. Actually the old age threshold is actually lower than that of, say, Uttarakhand, Punjab, or Kerala. Which means, another way of putting it, this is the age at which somebody in Chhattisgarh and Bihar reaches old age is actually earlier than the age at which somebody in Uttarakhand or Kerala or Delhi and Himachal is, right? So again, this argument or this analysis can be extended to rural urban differences as well. So here on the left is so we use the same standard population, which is the female population at age 65 in Kerala, because Kerala has the highest remaining life expectancy. And if that is a standard, what is the remaining life expectancy of India what is the age at which India reaches the same remaining life expectancy as that of somebody that of female population in Kerala? So we see that it's 58. And similarly, we also see an urban-rural differential, which means that in rural India, you reach or the old age threshold is lower than the urban Indian old age threshold, which means somebody in rural India is likely to reach old age at an earlier age compared to somebody in urban India. And similarly, extending this analysis can be done for every state in India. And here we can actually see that this argument that the rural old age threshold is lower, or the advent of old age in rural India is lower than that of their urban counterparts, is almost is actually same or true for most of the Indian states, except, say, a few states like Kerala, Gujarat, Orissa, or Uttarakhand. So most of the states, this is true. And continuing this argument again, thanks to this new work by Sankita Vyas and team, within a rural population, we can find the life expectancy across social groups, and then using the same standard population, I can look at what is the age at which different social groups are actually reaching the same remaining life expectancy as that of the Kerala female population. And then I could see that the age at which the advent of old age, or the old age threshold, is actually lower in SCs and STs compared to the higher caste. Very, very understandably so, because because of the life expectancy differentials, because of the healthcare utilization differentials. But the point being that the advent of old age in certain vulnerable groups within the rural India is actually earlier than that of the higher caste and even the obese. So that's the primary argument that I want to make today. That is that the way we understand old age is that we see it as for people above 60. We base our schemes based on that, etc. Whereas the meaning of old age clearly means different across populations, across spaces within our diverse country, right? So my own work has been based on continuing these arguments, which is on looking at further on gender differences or region specific differences, and then to add multi-dimensional approach into this, which means not just improvement in life expectancy does not always mean an improvement in health. You can have longer years of life with disabilities, vis-a-vis you can have longer years of life without disabilities. So if you add these additional dimensions into the calculations, the values will vary substantially. And then again, my work has also been on projections of these values to future aging. So these are the scopes and extensions of this approach to understanding population aging. And I want to call your attention to understanding population aging for using a dynamic threshold that accommodates for differentials in life expectancy, health, etc. So to conclude, to condense the arguments that I have made here, it is that population aging does not mean the same across different states in India, different populations in India, and rural Indian population actually reach old age at a much earlier age compared to their urban counterparts. And this is true for most of the Indian states except few. And that certain groups within the rural India are actually reaching old age at a much earlier age than their upper caste counterparts. Now, what does it mean? Often the arguments in the West has been about pension schemes and pension related reforms, but in our country, it's around 93% of the population is actually working on informal sector, where ideas about pension, etc., does not really make any sense. But it's not really about labor market reforms or pension schemes that I'm trying to make this argument in relation with. But the point is more about healthcare system, and that we need the healthcare system. The investments should be both short term and long term, and should be really focusing on old as well as early old. And this is particularly true for rural areas. We should, in our government schemes and in the schemes that we make towards elderly, we should be really sensitive to this differentials across spaces, and particularly to the rural differentials in reaching old age, and thus not be expand our scope to ages below 60 as well. And then our healthcare workers, as well as our informal care workers, including sometimes the family members, should be trained to deal with complex health system issues, including providing a life course perspective to understanding diseases and disabilities. And this also actually really calls for a more investment and understanding of preventive healthcare policies in India, and also a higher. We recommend a universal healthcare policy for the elderly population. So that's what I'm here to. This is expanding my methodologies to understanding population aging in rural India. I'm looking forward to your feedback and comments.
Thank you so much, Arun. Thank you for the presentation. So interesting, and I would really like to know some more things regarding how you read the implications from your analysis. Of course, I understand that there's a very limited time, so we don't know much of the intricate analysis that you have done. Maybe in the focus discussion we can bring those out. But I think if the key takeaway from your presentation will be to have a specific aging policy for different states in India. That's probably what you're saying, and also for different social groups. We have already started the program a little late, so I will club all the questions together at the end of the panel, if that is okay with you. And let me move on to our next speaker, who has been waiting patiently. And welcome, Dr. Apurv Soni. Kindly unmute yourself. Yeah. Dr. Apurv, let me introduce him to all of you. He is an assistant professor and a physician, and a champion for digital health at the UMass Chan Medical School, USA. Apurv is a physician scientist with doctoral training in epidemiology, biostatistics, and translational science. His program of research focuses on the use of technology in health services and community-based research. He is the director for a new program in digital medicine and led a team that focuses on the use of predictive analytics, mobile technology, and implementation science to improve clinical outcomes and reduce health disparities. His research lab specializes in real-world evidence generated through digital siteless studies, pragmatic clinical studies, and secondary analysis for large datasets to help deploy, validate, and evaluate digital technologies in healthcare. Additionally, Apurv is collaborating with colleagues from UMass Chan and other institutes to perform comparative effectiveness research, cost-effective analysis, community-based participatory research, and scenario modeling using simulation environments and agent-based modeling. Welcome, Dr. Apurv, and I guess we'll be speaking about child undernutrition and implementation of National Rural Health Mission in India today. And the mic is over to you.
Thank you, Ruchira, for that introduction. And I just want to confirm, can you see my screen okay?
Yes, we can see it.
Okay, perfect. And I label my talk here more focusing on the digital community health worker network for rural health in India, and recognizing kind of the urgency of this moment, especially in light of the post-pandemic, or as we are currently making our way through the pandemic, recognizing the effect that it has had, especially on health disparities. Um, I'll start by just providing an overview of the agenda that I hope to convey through my talk. One is to review evidence of impact of National Rural Health Mission on child undernutrition. Second, talk about how predictive analytics paired with digitally trained community health workforce can offer unique strategic advantage for rural planning in India. And third, talk about possible impacts beyond child undernutrition in creating this digitally trained community health workforce. I won't belabor this point too much, but to provide some context, I wanted to provide a snapshot of my journey so far. So I was born in India in the state of Gujarat. I moved to Massachusetts when I was in high school, received my formative education in the same state in Massachusetts, getting undergrad training in biology, and then finishing my clinical as well as research training from UMass Medical School. A little more than 10 years ago, I started collaborating with an academic medical center in rural Gujarat. And a lot of the work that I have been doing in context of rural health research in India has been through that collaboration. So I really owe a lot of credit to Dr. Somsekhar Nimbalkar from Gujarat, as well as his colleagues who have been mentors as well as awesome collaborators that we have continued to work closely with. In my current capacity, I lead a large NIH-funded program to understand how rapid antigen tests can be used in the home environment, as well as for our health system. I've led the creation of a hospital at home program so that patients can receive inpatient level of care while staying at home. With that background, I wanted to focus on child undernutrition today, which was the focus of a lot of my dissertation work. This may not be news to this audience, but India really is at the epicenter of child undernutrition. This data is a little outdated, but 1 in every 3 child in India under the age of 5 was reported to have stunted growth. And to really highlight that visually, consider this geographically accurate map of the world. And India is shown here, as everyone can pick out. But when we skew the proportion of the size of the country by making it proportional to number of undernourished children in the year of 2005, it really highlights what a disproportionate share of world's undernourished population reside in India. In that context, National Rural Health Mission, formed in 2005, was a flagship initiative to improve maternal and child health. The implementation plan was to focus on 18 states with the poorest health indicators, which are shown here in red highlights, as well as focusing on the Northeast states. And then in a stepwise manner, there was some programs that were also launched in the normal focus states highlighted here in blue, especially after 2012 when the National Rural Health Mission was scaled up to National Health Mission. The provision in the initial plan was for 30 evidence-based interventions for maternal and child health, and have 1 million frontline health workers trained and deployed in especially rural settings. So part of the work that I took on during my dissertation was to understand how did that impact different types of undernutrition. And this is a good visual representation of different types of undernutrition and how we can use anthropometry to approximate it. Acute form of undernutrition is measured by low weight for height. Chronic forms of undernutrition, and these are approximations, so there is definitely a lot of overlap between these three types. But for the sake of generalization, chronic state of undernutrition is considered as low height for age, and then mixed is low weight for age. However, when we combine all of them, we can also calculate a composite index of anthropometric failure. And so one of the first questions that we wanted to answer was examining the trends of undernutrition among children in India from 1992 to 2015 using National Family Health Survey data, and seeing if trends differed for different types of undernutrition before and after NRHM implementation. Did this vary based on state focus? And what was the impact on socioeconomic disparities, especially in relation to implementation of National Rural Health Mission? Findings that I'm about to present were published in PLOS Medicine, along with a lot of my co-authors, including some that are part of the WHO Maternal and Child Health Commission. The data source for this analysis came from Demographic and Health Survey data, the National Family Health Survey that was done in collaboration with Government of India. And that's a national representative data set. We were able to pull data across all cycles to end up with nearly 400,000 children under the age of 5. We excluded those children that were deceased, those that were visiting the household, those where anthropometrics could not be measured, and those that were older than 3 years of age, because there were some years where some of the data was not collected for that population. Ultimately, we ended up with nearly 200,000 children, and with survey weights, we were able to approximate population level and country level estimates. And so the design for the study was time series cross-sectional analysis, and we looked at the state focus classification as determined by National Rural Health Mission as the exposure, and the outcome was different types of undernutrition metrics. But we also looked at disparities in the context of wealth, maternal education, as well as rural versus urban location. And we considered different confounders because of known association with undernutrition. I would not spend too much time on the mathematics of it all, but happy to answer questions afterwards if there is any burning questions. Overall, we looked at predicted probabilities after adjusting for confounders. We also calculated change in prevalence over time using UNICEF's formula for average annualized rate of reduction. And we looked at socioeconomic disparities as a ratio of predicted probabilities for disadvantaged population over advantaged population. So anytime the ratio was more than 1, we considered that the disparities was increasing, and anytime it was less than 1, we considered that the disparities were decreasing. So I'll get into the findings. This is a graph looking at chronic undernutrition in blue line here. In 1992, it was approximated that there were 57% after adjusting for different covariates that were undernourished. And that dropped to 37% in 2015, which translates to a rate of reduction of 1.5 before NRHM and 2.3 after NRHM. So an improvement of 0.8% of undernutrition per year. However, the story gets a little more complicated when we consider acute form of undernutrition, because in fact that changed and increased after the implementation of National Rural Health Mission. And the overall, using the comprehensive index, did not have any measurable difference after the implementation of NRHM. It continued its downward trend of 1% improvement per year. This is only half the picture because NRHM was implemented in a segmented manner. And so we wanted to understand whether this differences in trends varied according to the state focus. So this is looking at normal focus states, and chronic undernutrition actually decreased much more rapidly after the implementation of NRHM in what we can call as control or normal focus states. However, in the intervention states, it still decreased, but not as rapidly as it did in normal focus states. And so the difference of differences was actually lower in intervention group in comparison to the control group. It's a little different story for acute form of undernutrition, where there was much starker improvement observed for acute form of undernutrition in high focus state, whereas in the normal focus states, there was actually an increase of acute form of undernutrition that was observed. And then for chronic form of undernutrition, there was no difference between the high focus and normal focus states. Finally, the third question that we wanted to understand was, did socioeconomic disparities improve after the implementation? And so this is looking at chronic undernutrition, and the y-axis is the predicted probability ratio. Again, any score higher than 1 suggesting that there is increasing disparity. And what this shows is wealth-based disparities was increasing prior to implementation of NRHM. The rate of increase slowed down, but it continued to increase. It wasn't reversing in terms of wealth-based disparities after the implementation of undernutrition, at least as it relates to chronic undernutrition. In terms of maternal education and rural versus urban, we didn't observe too big of a difference qualitatively, but statistically that we observed some measurable difference in terms of increasing disparities in comparison to the trends prior to implementation of NRHM. For acute undernutrition, however, we actually observed a reduction in disparities across all different socioeconomic indicators. And so taken together, what we found was chronic undernutrition had a declining trend before NRHM, which continued but at a faster rate in normal focus states, which were actually where the interventions were not focused in as much with as much intensity as in high focus states. However, socioeconomic disparities for chronic undernutrition persisted or exacerbated after rural health mission. However, for acute undernutrition, there was a declining trend before NRHM that continued to improve, and even at a faster rate for high focus states, as well as socioeconomic disparities reduced after the implementation of National Rural Health Mission. And then overall undernutrition, which in some manner is a combination of the two of them, we were not able to measure too much of an impact in association with National Rural Health Mission. And so the takeaway is National Rural Health Mission may have been effective at addressing undernutrition in acute form. However, increasing acute undernutrition in normal focus state was a concerning observation. And this really highlights that in the context of limited resources, we need to have better strategies to identify and reach vulnerable populations. And which brings me to the second part of the presentation, which was to understand if we can use risk factors for child undernutrition to inform a public health strategy, and whether that can be used to predict risk of child undernutrition at the time of delivery, so that better allocation of resources can be achieved. We use the same data or same source, but for predictive model, we focused on, at that time, the most recent data available, which was 2015 to 2016. Recently, a newer cycle of NFHS data has been published, so we are working on updating some of these predictive models. The data I'm about to present was published in Lancet Global Health as well as Journal of Global Health. So in total, there were about 54% undernourished children that were used to inform this model. We included 15 variables in the final model, and the overall accuracy is measured by area under the curve, or C statistic, was moderate at 0.68, and the Breer score, which is a measurement of how much information the predictive model provides, was also moderate at 0.22. The point of this output of the model is not to go over the detail of the coefficients, but rather to highlight that most of the information that was used in the predictive model is already being collected in birth registration forms, and there are only a few questions related to built environment and actually the housing environment that needs to be collected to on top of what's already existing in birth registration and publicly available data that can be used to build this predictive model. In terms of how it performs, the best way to think about it is, does it achieve the function of helping risk stratify the population into categories that have different risk of undernutrition in the first 5 years of life? And so we were able to risk stratify the population into 10 categories. And on the middle column here is what was observed rate of undernutrition, and on the right side is what was predicted or forecasted rate of undernutrition. And what we were pleased by is the predictive model very closely maps to what was observed. And this was done based on bootstrap validation analysis, so which is one of the more rigorous way of evaluating your predictive models. And the takeaway from this was that we can, using predictive model, have an anticipatory rather than a reactionary approach to child undernutrition. In other words, not wait for the child to be undernourished before they are eligible for resources, and rather identify children most at risk of undernutrition and have early intervention. One of the things that want to highlight as well is more than 80% of births are now starting to be registered by frontline health workers using mobile technology called eMamta. And as I highlighted before, all except for 4 of the data elements are already being, or 5 data elements are already being captured. So part of a low-hanging fruit is to be able to add 5 questions so that the mother and child tracking system itself can calculate a predicted risk of each child that's registered in that system of being undernourished or in the future. And this can be leveraged by government to efficiently allocate resources at state and district level, by local administration to prioritize at-risk children, and by village health workers and community health workers to follow up with high-risk children. In the context of National Nutrition Mission, which invest large amount of money over a 3-year period to converge various interventions addressing malnutrition, as well as integrate information technology-based tools to improve efficiency and support for frontline health workers, I submit that this is a useful strategy to consider. However, it requires a pilot testing as well as more implementation science of how this model would continue to work in real-world setting. We also recognize that this model is not going to be something that's static, and it would benefit from having new data come in, which allows us to retrain the model and improve upon it. And we really think the integrating this risk score algorithm in the National Nutrition Mission app would be a wise and strategically important step forward. And Ruchira, can I get a sense of how much time I have? Because I have about 10 more minutes of presentation, but I want to be mindful of time.
Please go ahead. Please go ahead.
Okay. So changing topics just a little bit and highlighting some of the other work that we have done as a way of showcasing promise of digital medicine when paired with community health worker. we did a study focusing on atrial fibrillation in rural India, and part of the reason why we focused on atrial fibrillation is it accounts for 1/3 of all strokes that are observed, and stroke is often the first symptom of atrial fibrillation, meaning that oftentimes it's atrial fibrillation is detected after the fact, after a stroke has occurred in a patient. However, treating people who have atrial fibrillation, which is a type of arrhythmia, with anticoagulation treatment can reduce the stroke risk by 2/3 and mortality risk by 1/3. However, the um, global burden of disease study, when it reviewed prevalence of atrial fibrillation, it created this map across the world, which orange and red highlighting shows high prevalence, and green and blue shows low prevalence. And one of the things that we took away from this was not necessarily that this is an accurate representation of the burden of the disease, but it's an accurate representation of where health services are available more comprehensively, such that AFib is detected. What we also know is stroke is the third largest killer of adults in India. And again, using the same technology, if we distort the map of each country proportional to number of deaths due to stroke, it's clear that India has a disproportionately high number of strokes and deaths related to stroke. That said, the prevalence of AFib in India is really sparse. Prior to our study, there was only one other study that looked at it in a community-based setting, and that was focused mostly on younger population and only found 0.1% prevalence. So instead, what we did was we had a village health or village network of 50 villages, and we were able to do population-based sampling from there, use mobile technology, a smartphone-based app device as well as an app to detect atrial fibrillation, and then confirm it with a standard EKG, which is the gold standard way of confirming atrial fibrillation. And we were able to identify high-risk population for stroke that were started on anticoagulation, and low risk that were told about their condition of AFib and had follow-up care. And a lot of this was achieved by village health workers that were able to use mobile technology and screen people for atrial fibrillation. Ultimately, we enrolled about 2,100 participants with a response rate of 91%, and we published the results in International Journal of Cardiology that showed that age and sex stratified AFib prevalence was observed to be twice as high in rural India than in US and Europe, which really challenges that global burden of disease map that I showed earlier. And ultimately, I'll end by this guiding principle that my lab has, which is making sure that we take all efforts possible so that these very interesting practical solutions that are facilitated by digital medicine do not remain inaccessible to people who need it the most. And that was inspired by one of our colleagues from Kenya who presented and challenged us on this problem at a global health technology panel in 2016 when we presented some of this work. I'm including my email address here and look forward to answering any questions audience has at the end of the panel.
Thank you so much, Apurv. Thank you for this detailed and very meticulously done presentation. We will, of course, take some questions, and we have a few people who work on nutrition training in this among the audience itself, and like to know some of the things that you have done and what are the implications later on. You were talking about solutions, and talking of solutions, let us move on to our next presenter. Dr. Bhaskar, are you here? Am I audible?
Yes, Dr. Bhattacharya.
Yes. So let me introduce Dr. Bhaskar to you. Dr. Sonu Bhaskar is a physician scientist and the director of Global Health Neurology Lab in Sydney, Australia. He's also the founding director and chief investigator of NSW Brain Clot Bank, a flagship world's first initiative established with funding from NSW Ministry of Health in partnership with NSW Health Pathology, local health districts, comprehensive stroke centers, NSW-based Medical Research Institute, and community. Dr. Bhaskar has several years of leadership and governance experience in initiating and delivering systems change in senior leadership and executive roles at academic, healthcare, and research organizations and not-for-profit boards and international consortia. Dr. Bhaskar leads national and international initiatives on reducing health disparities with a focus on vulnerable populations and under-resourced settings. Since 2020, he has led several expert committees and contributed to policy briefs on COVID-19. He is the recipient of prestigious national and international awards, including the EU Marie Curie Fellowship, Spanish Ministry of Health Fellowship, Dutch Ministry Top Talent Award in Biomedical Sciences and Medical Innovation, Professor A.R. Rao Young Scientist Award. He is in the two-time winner of 2019 European Academy of Neurology Investigator Award, the 2020 Rotary Vocational Excellence Award, and the 2021 Paul Harris Fellow recognition. Dr. Bhaskar has developed an international profile as a key thought leader and communicator in global health neurology, innovation, and research partnerships, underscored by the local and global impact of his leadership and initiatives on health systems and communities, strategic and engaging multi-scale stakeholder engagement experience, and an extensive publication record. His international record of exceptional and outstanding achievement has been recognized by the grant of a global talent visa by the Australian government, allowing him to work and live permanently in Australia currently. Dr. Bhaskar, before you start your presentation on the global solutions to accessibility in rural health and the equity issues, let me just ask you, can you just quickly introduce about the reprogram initiative that you had done? Maybe tell us a few things about that and then move on to your presentation.
Definitely, Dr. Bhattacharya, and it's absolutely an honor to be part of an important initiative that your institution is leading with the government of India. And I'm very happy to be a part and give some policy recommendations based on some of the work that we are doing internationally. And today I'm gonna, in my presentation, will share some insights of our work in low resource settings from Africa, and of course, which has implications for India, which may be of interest to the audience who are joining us today. The Reprogram Global Consortium was conceived at the beginning of the pandemic in 2020, when you know that the pandemic has severely impacted communities around the world. But what really the pain point for us was that although there was a lot of focus on the developed world, America, Australia, UK, and European countries, much of the developing world were not in the focus of the global health narrative that was being spelt out. And whether it was resource mobilization, human resources for doctors, supply of medical equipment, so on and so forth. And that crippling nature of the global health in the developing world was a pain point for me. I'm a neurologist and a clinician who is really passionate about low resource settings, because I think the global narrative should change from the Sydney and from London, from Washington. It should go to Delhi's and streets of Gujarat, because that's where the global health should sit, in really about empowerment of clinicians who are working at the grassroots levels. And that was where we reached out to my colleagues and friends around the world. And I'm so happy that about 25 countries and more than 150 physicians working at the front line of healthcare joined the consortium, and we started working at fundamental questions, not really basic level research, but fundamental questions from a policy level. And that's how the Reprogram Consortium was born. And we put a lot of efforts in terms of the legal ramifications, the governance around global health architecture. We brought expertise from legal perspective, also from management perspective, and saw that what are the global architecture that we need to conceive to really create sustainable healthcare systems for future, which has a narrative that comes from the grassroots movement in low resource settings. So not just informed from a top-down approach from the developed world, but is actually informed from the developing countries. So really talking to the peers, but understanding the nature of the need that we need to address. And that's what the consortium has been doing for some time. And over the last 2 years, we've done enormous amount of work and published policy briefs. Much of these recommendations have now been adopted in several developing countries. And now we are starting a pilot initiative countrywide initiative across Liberia, Guinea, and in the Western Africa. It's called the Manu Africa, which is a river that floats between 3 countries. And why we chose this country? Because I think Dr. Soni was talking about maternal and child health. If you look at the denominators of the world's poorest population, which fares at the bottom of the denominator in the world, are these 3 countries, where the child and maternal mortality is one of the highest in the world. And I thought that why don't we start with the populations the most vulnerable, and then we scale out to other populations which can take insights from that particular angle. And that's how this consortium has been doing a lot of work in the policy brief, but then really working at the grassroots level to implement changes with the government, with the political leadership to really inform. I truly believe that health is political, and no much of how much of evidence-based work we do, if we do not involve all stakeholders, right from the government all the way to non-government organizations who are working, we will not be able to sustain fundamental change. I sit on the board of several non-profit organizations, Rotary International, International Rotary Foundation Directors. I've just become the chair for Global Health Hub in Germany, which is by the Ministry of Health in Germany. And fundamentally, it's so important that we should be talking to the government, sharing, understanding their grievances to inform that policy bridge that has been a big cause of concern. Because we publish a lot. Unfortunately, much of the publications don't really make into evidence-based recommendations. And it's important to work on that bridge to bridge the best of evidence and support how that can be implemented in the grassroots level. So I hope that gives a bit of brief introduction about the consortium work, Dr. Bhattacharya.
Thank you for introducing about the program that you have done. I would request you to now move on to your presentation of the day. And
I am unable to share my presentation because it says that it cannot be shared or something.
let me quickly see if I can give you the host controls. Yes, you are the meeting host, but can you find the present now box at the bottom?
I am. It's a browser problem, so I'm just going to start with maybe on a different browser because it says the browser is not
Dr. Bhaskar, if you do not mind sharing the presentation with me, then I can share it from my end and you can present, if that's okay.
Yeah. Dr. Bhattacharya, the problem is the presentation is very long and it's about 2 GBs.
Right.
So but I'm trying to restart the system. So if you don't mind, I'll just restart the system.
Yes, sure. Please take it. While our speaker joins the meeting, he's trying to, yeah, I think he's back here. Let's see his presentation. If you minimize the window, Dr. Bhaskar, and start the presentation, we will be able to see it. We can see your screen now.
I think sir is in mute.
Right. Dr. Bhaskar, if you can hear us, you will have to join in normal mode. In companion mode, you will not be able to unmute.
Am I audible now, or?
Yes, yes, you're audible, Dr. Bhaskar. You're audible. Yes.
Oh, fantastic. So I would start the presentation. Sorry for this technological glitch. Today I'm going to talk to you about building health systems in low resource settings, and we'll discuss some policy indications with a focus on rural India. I'm the director of Global Health Neurology Lab in Sydney and founding director for New South Wales Brain Clot Bank, which is an initiative that brings together several university hospitals, universities, research institutes, and public services in New South Wales in Australia. Well, I'm a neurologist. I've always been fantasized by Santiago Ramon y Cajal, who is often called the father of neuroscience. And one of his quotes, "The brain is a world consisting of a number of unexplored continents and great stretches of unknown territory," has an implications for global health. Because I think we are exploring the world now with those unexplored territories and continents. And I believe by focusing on the low resource settings, we can really imbibe a much more better understanding of global health. What is
Dr.
global
Bhaskar,
health neurology?
I apologize for interrupting you. Can you kindly change the slide in the file as well? Because we are, yeah.
Okay.
Please put it in the slide mode.
Okay. So is it okay now?
Yes, we can see the file that you have opened, but if you have started the presentation, we are not able to see the presentation mode.
Okay, so I'll put it in the file mode then.
Yeah. Okay.
So basically, we are really dedicated towards preventative health approaches towards in global health and seeing how we can benefit the most underprivileged populations. Much of our work is around health systems innovations and also translational neurology, neuroscience innovations. So we're looking at innovations that can work across complex health systems, as well as really transforming the bench to bedside approach to see how we can inform our knowledge moving forward. So what do? We develop low cost, open source and scalable innovative solutions. And our focus is on low resource settings and disadvantaged communities. And our mission is to save billion lives globally by humanizing and transforming healthcare through cutting edge neuroscience and engineering. And Great Works is basically a collaboration between wonderful group of people I work with, and I had the privilege to work with. They all come from, they're neurologists, clinicians, engineers, and biomedical scientists. Now, what is the need for what we do? As you know, the several neurological conditions presently have no viable treatment. And their prevalence and the burden is dramatically increasing, not just in the developed world, but also in the developing countries. And they pose a major global health and societal challenge. Specifically in India, we are seeing increasing rates of stroke and other vascular conditions. More so, the treatment and management of these diseases have been fundamentally and challenging in the low resource setting. So there is a huge prerogative to work towards parity in global health and neurology in particular. Now, what mediates outcomes in neurology and global health in general? The places we live, work, and feed, all of these determinants, the so-called social determinants of health, play a major role in how we respond to diseases, how we develop diseases, and how our diseases chart over time. Today, I'm going to give you an outline of what is the pressing need for what we should be doing, a brief introduction about Reprogram Global Consortium, which I have talked in briefly before, and some policy briefs and how can we use integrate technology, specifically artificial intelligence and blockchain technologies, to inform the health system's capacity to intervene in emergent crisis. And we'll really give some indications for policy prerogatives with a focus on India. And then I will conclude with some concluding remarks. Now, much of my work is around stroke, primarily because of my training and clinical focus. And what we were observing in stroke, there was a lot of inconsistent care practices. And those inconsistent care practices, which we often see in the, not just in the developing world, but also in the developed world, they adversely affect outcomes. They impact our patient safety, the performance measures, and they cause a huge burden to our health systems. So just to give you an indication, from a developed country perspective, wasteful clinical spending is 1/5 of the total cost of healthcare. So there is definitely great importance that the developing countries are focusing and developed countries are focusing on, is to reduce the variations in clinical care across the continuum of care. And that's where the Brain Clot Bank initiative came first. It is an Australian first and presumably world's first initiative. We are setting up biobanking procedures and workflow practices of how we can harmonize the stroke care practices across the state. And we have developed strong collaborative networks, really bringing together hospitals, public hospitals, to see how we can imbibe those bench to translation perspective. It is funded by the Ministry of Health in New South Wales government. So that just gives us a brief understanding of what the present landscape looks like. When we started before, there was large variability in the clot thrombi assessment across the centers in New South Wales. Now, since 2015, one of the only fields of neurology that has dramatically evolved is stroke, because now we can offer endovascular treatment. For many of you who are not from neurology, endovascular treatment is a procedure by which we can pull the clot out of the brain, and the patients show dramatic improvement in their functional status. So there is obviously a greater focus on really providing endovascular treatment to our patients around the healthcare services. However, there are lack of standardized protocol with specifically on the clots retrieved from that procedure. And there are no current guidelines in terms of how the clots should be handled, so on and so forth. So there was a health systems narrative that we wanted to address. To give you a brief understanding of what endovascular thrombectomy is, so here is a particular schematic of a clot, as you can see in the artery, which is blocking that artery in the brain. And through that catheter that we can now pull that clot out of that particular artery that is being obstructing the blood flow into the brain. And once that clot is retrieved, patients can restore, their blood flow to the brain is restored, and then dramatically improves outcomes in these patients. Now, what we are now trying to do is to use imaging as well as advanced histopathology to really characterize these clots. To give you an understanding of the health systems architecture around it, so there are several hospitals, public hospitals, who are part of this partnership. And we have just started a satellite initiative in Walter Center in NHS in Liverpool in UK. Now I'll start with the second part of my presentation, which is about what is the pressing need of what we should be doing. As you know, the global health has been dramatically impacted because of COVID-19. And this is a stat from some time back, but you can see that the proportion of people who are dying because of this pandemic has dramatically increased over time, and it poses a huge burden. Now, there are two important aspects of COVID-19. One was the acute effects of COVID-19. As you can see, the mortality was humongous. Even it had great implications in India. But also there was some chronic impact of COVID-19 that I will briefly discuss. From a chronic and acute perspective, one of the important policy question was that how do we maintain continuity of care and the capacity of health systems to deliver continued access to patients who are diseased, who have neurological diseases during COVID-19. And much of the delivery of care in COVID-19, even in low resource settings, moved from conventional care to telemedicine. So fundamentally, the COVID-19 has transformed that way we deliver healthcare services, even the specialist services, neurology, cardiology, so on and so forth. Is this the narrative that we want to build for future, and whether this has implications for low resource settings? This is where the Career Program Global Consortium was born. Our focus was really to understand how this crisis is impacting healthcare systems, healthcare workers, and communities. And we brought together a team of really highly diverse people from multidisciplinary, clinical, and other backgrounds to understand and champion the safety of healthcare workers globally. And our philosophy was that we don't leave anyone behind. Much of our work has been published in it's an open access platforms, and they are evidence-based treatment recommendations to build capacity in low resource settings through collaboration and telemedicine technologies. One of this work, which was in collaboration with Thomas Jefferson University in US, where, as you know, acute stroke services was heavily impacted during COVID-19. Patients, despite experiencing acute symptoms, were not turning up to the hospital. So there was definitely an important narrative from an advocacy perspective that we need to tell the community that if you're experiencing symptoms of cardiac arrest or of stroke, then you must still come to the hospital and access the services that we can provide. So we started with some recommendations for community, but also recommendations to change the way we deliver treatment, because from a healthcare perspective, using personal protective equipments, so on and so forth. Much of this recommendation is in public domain. But the second part of that public policy perspective was, how do we integrate telemedicine in how we deliver healthcare services? And when we understood that the telemedicine infrastructure across the world is varied and crippled in several countries, and when we are talking in developed countries about integrating artificial intelligence and technologies, many of the countries don't even have the basic resources such as sufficient bandwidth to communicate between physicians or between hospitals. So where are we? And that's fundamentally the first question that we wanted to address in Telemedicine Across the Globe position paper, where we looked at across the continents and countries to understand the policy gaps between the infrastructure and what are the areas that we can really deliver in terms of governance, in terms of resource mobilization, so on and so forth. I will highly encourage you to look at this particular paper. But then from a country-wide perspective, we went much more granular. We went to the discipline-wide specific recommendations for patients from neurology, from cardiology, pediatrics, so on and so forth. And much of these recommendations is now in public domain, but we actually recommend that telemedicine based infrastructure, for it to be harmonized across sectors, it needs to a much more granular and policy-based initiative. And it should really consider acute care and of course the chronic care, because the needs of these populations are substantially different. Lastly, an important consideration during COVID-19 was an acute shortages of medical supplies across the world. In India, you had seen the shortages of the oxygen ventilators across India, and it caused a huge furore and public concern in India. So we put together a team from UC Berkeley, from National University of Singapore, from University of Copenhagen, and we looked at the policy indications that we can provide in terms of supporting and reducing the supply chain debacle that happened in this country. I just want to take you through that particular policy recommendations. If you look at this particular thing before the pandemic, how the countries procure medical supplies from the suppliers, which is predominantly in Asia or China in particular, there was the supply. When there is a demand, you procure the particular supply from the supplier. But during COVID-19, initially when the demands really aggravated, there was a huge breakdown of trust in between suppliers and procurers. So governments were finding it hard to procure the basic necessary supplies during the pandemic. So what we proposed was to cut the middleman out and use technologies, blockchain technology. So blockchain is a platform where you can maintain the privacy of the supplier and the procurer while maintaining all the other supply chain chain demand. So when even the supply or the demand increases, you can use this technology to procure and build trust and a fair pricing model that supports both the sides of the stakeholders. And that particular recommendation involves setting up a national command center, using blockchain technologies and big data analytics to procure and monitor the demand as it progresses. But it also recommends regional stockpiling. So for Asia, India could be a leader in terms of stockpiling basic resources which other countries around India might need when the future pandemic hits. So we're talking about the technology as a connector of the basic needs of the organization and governments as it evolves. So what were our recommendations for building health systems resilience during the pandemic, so on and so forth? Much of our recommendations centers around integrating public health response very much as a part of the COVID-19 strategy. Embedding telemedicine and technologies such as artificial intelligence will be critical to how we should shape our international and national guidelines for health systems preparedness. And most importantly, we gotta have international standards of interoperability of data sharing. All the data and the network between governments are fragmented. Even within countries, institutions don't talk to each other. So it's so important that during pandemic, we need to have the interoperable and data sharing between continents as well as within the country. Having open platforms, not proprietary platforms, which can support open access sharing, democratic sharing between institutions, which are cost effective, are critical. And that's what the governments need to invest in that space. But technology is not the solution for everything. Improving digital literacy and language barriers is a huge problem. In India, a complex country like India, where people speak different languages, you cannot have one size fits all approach. You need to tailor it to the demands and the cultural linguistic requirements of different parts of India. So it's a major impediment to really make technology accessible to the people in the community. And most importantly, investing in the regional effort in building pan-European, pan-Asian initiatives that can develop regulation governance frameworks around COVID-19 is so important. Lastly, we made a recommendation that our future response to COVID-19 and health systems resilience should hinge around vulnerable communities. The way government responds should be how we respond to the vulnerable communities, because that's the community that's mostly affected. They don't have the resources to impact, and that's where the macro financing strategies could be of huge help in building that supporting structures around them. So our recommendations were hinged around building the future of telemedicine around futuristic telemedicine, integrating artificial intelligence, blockchain technologies, developing frameworks that can be sustainable and cost effective. To give you an example of this particular artificial intelligence assisted telemedicine platform, that as you know, the diagnosis is a multidisciplinary process. For example, when stroke happens, to make a diagnosis of stroke, you need a specific set of diagnostic platform. You need blood tests, you need multimodal imaging, CT imaging. Once you detect the vessel occlusion on a CT angiography, then you go on to advise patient whether they actually need endovascular thrombectomy. Now, to make this telemedicine-based diagnostic easy and streamlined, we need to have assisted artificial intelligence assist telemedicine that can help physicians to make the decision at a much more faster scale. Other problem with telemedicine has been that the systems are fragmented. Hospitals don't talk to each other. So let's say when a patient with a stroke in the southwest of Sydney has a stroke, and they go to the nearest hospital, but the hospital doesn't have a capacity to deliver endovascular thrombectomy. Now, how do we make this streamlined movement of patients so that they can access the best of services and appropriate services is so important. And that's where the artificial intelligence can help us building that architecture. To give you an example, in Sydney at the Royal Prince Alfred Hospital, during the COVID-19, they set up an RPA virtual hospital that used artificial intelligence to monitor key biological parameters in patients who were at home but being monitored using a nurse practitioner who was monitoring these patients and then digitally monitoring them over time as long as they're COVID negative till that time. And that had shown great impact in the community and was very positively undertaken. Now, robotics can also help. And using robotics to prevent the impact on healthcare workers, but also the patients, could be key to our sustainable plan to address pandemic. But most importantly, how do we address a future outbreak in future? And robotics can be used to draw and monitor infections, measuring vital infections, disinfecting, border control, so on and so forth. And all of these technologies should talk to each other and make sure that artificial intelligence is very much part of it. Lastly, I want to talk about organizational framework around telemedicine. Now, this is key from a health systems perspective. Much of the architectures around telemedicine can be clubbed in different formats or frameworks. One of them is a decentralized framework where you have all of them talking to each other. Sometimes they're very chaotic and are not very efficient. There's another framework that is centralized, so that you got an apex government on the top, and then the systems are laid out at the bottom. Then you got a hub and spoke model, which is much the stroke network uses. So you got a hub where the endovascular thrombectomy treatment can be provided, and then you got the spoke networks where the patients can be thrombolized with intravenous thrombolysis. And then you got a holistic and a Dandelion model where there is like a hub, small little hubs, and then the spokes all spread out. All of these systems have their deficiencies. And that's why we propose to build a futuristic telemedicine. We need to kind of have a stage-wise approach to telemedicine, where we use the conventional traditional models, and then slowly, the artificial intelligence-based platforms can take over. To give you a much more simplistic example, when a patient presenting with a stroke is captured by an ambulance in a local rural health district, then they can inform the artificial intelligence-based pipeline, and they can select the most available and critical and nearest center that can offer endovascular thrombectomy treatment in the shortest time, and the patient can be routed to the nearest hospital, and then the treatment protocol can follow. So artificial intelligence telemedicine framework can be a huge, basically a broker between the best of services from the providers and to the patients. And this is how the architecture looks like. And we propose that artificial intelligence, robotics, and telemedicine should be, on a holistic level, should be integrated in how we challenge the traditional organizational structures, but how do we also streamline and reduce inefficiencies between the systems, so on and so forth. Lastly, I'm going to talk to you about pooling physicians. Now, because in low resource settings, we have got limited resource, we cannot just produce doctors on a scale that we need. We need much more innovative solutions for telehealth monitoring. And I think that's the reason, that's where the telemedicine informed frameworks have a huge role to play in low resource settings. For example, and this is a beautiful quote by from the Director General of WHO, and he says that it's completely unacceptable that half the world still lacks coverage for the most essential health services. So what are the pain points that we observed across in the developing world, but also in the developing world? The non-communicable diseases are a huge burden, and the burden is increasing over time. And as the access to, there is a fight to access essential health services, the essential health services are crippled. And then you've got external factors like COVID-19 that exacerbates that access. So access is critical, and that is being debilitated during these times. The second is a human resource problem. We don't have sufficient doctors, we don't have sufficient nurses, or we don't have community health workers to support the kind of access needs that we have at this time. And there are disparities of care that's available across sub-Saharan Africa. Then of course, there are disparities of care across disciplines. Much of the neurology, acute neurology services that are provided in developed world is not available because of lack of appropriate services and physicians who can deliver those services in much of the low resource settings. So how do we counter that? What is the need, and what are the possible solutions that we can address this huge gap of healthcare workers, which is a huge problem in the developing world? Our solution, and this is where I would like to really focus on Indian perspective. In India right now, as you all know, that there are layered structure of how we deliver in rural health India. We've got sub-centers, we've got primary health centers and community health centers. And this bartending between the tertiary care hospital and the patients is in itself is a huge challenge. In India, across the Indian subcontinent, we've got 680 638,000 villages, which inhabits more than 740 million populations. That's about close to 1 billion population. And I think Dr. Soni indicated about the NHRM program. There was a policy promise by the government that they're going to increase the expenditure from 1 to 3% of GDP. Of course, we have to follow through how much of that expenditure will be made. However, the expenditure increase is not an antidote to health systems problem. If not crafted along with appropriate policy reform and supporting infrastructure, no matter how much you spend, which US is best example for it, they have a huge public health expenditure that goes into supporting healthcare systems, and still the system is unaffordable, unsustainable in several parts of America. Only 20% of those seeking outpatient services actually avail public services in the rural India. And only 45% of those seeking indoor treatment avail public services in India. So just public services is not enough. How do we educate patients that they should be accessing these services is equally important. Now, I've just listed some of the pain points which, talking to different stakeholders came to my knowledge. And in the last couple of days, I've been talking to a lot of my friends in India. Some of these pain points are the poor state of infrastructure in rural India, which kind of dissuades patients to go there. Patients don't feel safe that accessing services in the local village will be appropriate for them. They travel much far to the city hospitals to gain those services. Poor supply of drugs and equipment. Even though you have doctors in some places, there are insufficient amount of supply of drugs and necessary equipment to provide the best of services. And most importantly, it is astonishing that in India, there is a huge problem in employee absenteeism. A lot of healthcare workers don't turn up to their provider facilities, and many of them do have private facilities where they are serving patients. So this gap between integrity and absenteeism is a huge problem. Lack of appropriate training. There are not many credentialed nurse practitioners or the healthcare physicians in rural India. Insufficient human resources, where the credentialing is such an important aspect. Inconsistent care practice, which I started at the beginning of my presentation. There are not evidence-based strategies that are followed across the hospitals, and that really also goes on to poorer outcomes for our patients. A lack of evidence-based care. So what could be the policy recommended? We talked about the pain points. What are the policy recommendations to build a sustainable health systems for rural India? The first starts with building an agile, lean, and technology-enabled systems. We need to cut down these three architecture we have, the subsystems, the community healthcare platform, and really make it more integrated and build a more agile and technology-enabled systems platforms. Use micro and macro finance strategies that could include cash transfer from the poor to access outpatient services. Much of this PM Yojana that you have, Ayushman Yojana, doesn't cover outpatient services. It's important to support that in the most vulnerable populations in India because they don't have the sufficient resources even to access outpatient services. Of course, the insurance will cover the inpatient services, but also to look after the outpatient services is equally important. And that's where the preventative medicine plays a key role. Investing in portable and modular healthcare infrastructure is important. We can't just rely on 18th century's platforms to enable the 21st century's demands of our populations. We need to look at more modular solutions. We can look at Army, how they mobilize and integrate solutions which are more portable and modular, that these enabled systems can provide diagnostic services and they can also be moved around across the villages. Incentivizing rural health placement for healthcare workers is important. An important issue in rural India is many of the doctors don't want to go there and serve the populations. So providing incentives, bonuses, salary bonuses, perks, and career progression, which can be in fact outweigh the urban placements, can be a target and attractive option for them to go to rural India. So if you're given 20% or 10% more salary to these healthcare workers, they feel incentivized and rewarded for what the services they can deliver in these pockets. Compulsory rural health elective for 6 months during medical school. I really believe that 6 months of rural placement in the young, brilliant medical students that they can get exposed to rural healthcare in India is important. Of course, that can follow up with 1 to 3 years during residency. Integrating telemedicine, not just in the delivery of services, but in the medical education. that they can talk to the rural health practitioners and get some insights of treating and managing patients in rural health. It's different from the urban settings. And leveraging, as I said, leveraging AI, robotics, and disruptive technologies and how we deliver and best of treatment for our patients. And really, we need to move from that acute state, a kind of reactive stage to more preventative approach, which could include social prescribing, so on and so forth, in these rural architecture. What is our framework? And we call it the Reprogram Global Health Matrix. It starts with partnership. Important for the global health architecture future, we need to build partnership between community healthcare workers, community leaders, Ministry of Health, and local non-government organizations. And innovation should be key to this partnership, using telemedicine, common dashboards that can be monitored, that how that community health worker is actually going on to the particular patient, following up on that patient, taking the necessary blood draws, and looking at critical risk pregnancies, so on and so forth. And understanding that portable and scalable infrastructure is important, not the conventional 16th century infrastructure. Linking these infrastructure to academic health centers is equally important. Much of the patients from rural health India then go on to AIIMS, All India Medical Sciences in New Delhi or other places to access specialist care services. However, clinicians from these specialist services have no information on the background of this particular patient. So we need to have electronic medical records that talk from the local centers all the way to this tertiary care, so that the entire continuum of care for that particular patient is streamlined for the treating physician. On this regard, we have a particular trilateral training pathway that we are developing for Mano Africa initiative that focuses on cardiovascular and neurovascular specialization. As you know, the cardiac care and of course the stroke is one of the leading causes of burden around the world. So we're really focusing on these two important aspects. We also believe that focus on education, training, and human resource capacity is critical. We got to incentivize our community healthcare workers, our physicians, to go out there in rural clinics and support the infrastructure and building. If we don't incentivize them, it really hits down on their morale over time, and many of them are not enough inspired to serve in these services, and they go back to the big cities to serve patients where they can make much more lucrative packages. Finally, just to give you a brief initiative about the Mano Africa initiative, which is really about building health systems resilience across and supporting neurological and cardiovascular specialist care across 3 countries, Liberia, Sierra Leone, and Guinea. And we have a great champion in Dr. Masuka Fala, who is supporting and leading it in this continent. And of course, that is in partnership with the Ministry of Health in these 3 countries. In conclusion, we believe that focus on building and delivering fast, accessible, scalable, and effective healthcare services is critical to building health capacity in rural parts of India, but also in low resource settings. And to do that, we need to really think about artificial intelligence robotics at the design stage. So we can't go to the solution and then think about going back to the problem. We need to think about from the design stage how we can integrate artificial intelligence and disruptive technologies to support the infrastructure that we need for future. And in that process, artificial intelligence-based frameworks can be a huge enabler for our access and penetration across these countries. And lastly, we need to integrate efforts between government, non-government organizations to see that this is properly monitored and these access points are regulated over time. Lastly, I just want to acknowledge that work is done in support of great people I work with, and I've got an extraordinary team of more than 25 young and brilliant physicians who are working here. They're very passionate about global health and neurology, and it's because of all of their efforts that, a team like this, we are able to perform and deliver in the best interest of our patients and for our communities. Lastly, I'll leave you with this particular slide. And on the bottom, as you can see there, the koalas, which is very much specific to Australia. 2 years ago, there was at the time of COVID, we had a bushfire in Australia where the entire population of koalas were wiped out from that particular pocket. And in that bushfire, still the koalas were huddling together. So it just reminds us that not just to humans, but compassionate care is integral to humanity. And the way we look after our patients and our communities is integral to how we respond to treatments and emergent needs when the future pandemic hits us. I thank you for your indulgence and look forward to listening to your questions.
Thank you so much, Dr. Bhaskar. Thank you for these very insightful policy recommendations that you have given us, and so much hope for a country which is in a low resource setting to kind of overcome the inequity issues that we are facing. In fact, when we were talking about, you were saying about the 3% GDP, to health, and I was just thinking that how much of it really goes into infrastructure and technology, and how much really goes to the salaries and manpower cost that really needs to be seen. Let me open the floor for a question now, and I think the participants can unmute themselves, or you can raise your hand and we will unmute you. I remind you that we have clubbed all the 3 question and answer sessions together. So if you have any question, please raise your hand or put it in the chat box. We will read out for you. The floor is now open for questions for our speakers. Dr. Lakhan, would you please unmute yourself?
Yeah, good morning to Ruchira madam and all the panelists. They deserve really a great appreciation for their brilliant presentation. My clarification to Dr. Arun Kumarji. You showed one slide where you showed a comparative, picture of SC, ST, and other caste and higher caste. They related to threshold age, if I remember correctly. So that there were almost 4 years gap. I mean, there was 4 years difference between SC, ST, and the higher caste, the threshold age group. So would you recommend that because there are so many policies in India which are, applicable to the old age people who have crossed their age 60 years and above. So in case of, marginalized section people like SC and ST, as your result has showed that, and even your analysis was at the national level, not even rural urban, which you have showed. So probably if you analyze at rural and urban, then again it will go down. It is my hypothesis. So would you recommend that the government of India, basically the Ministry of Social Justice, Ministry of Rural Development, and some other ministries, they have so many programs which are not, because of their age, they may miss those opportunities. So their schemes and the programs should go to the people of this marginalized community before, I mean, as of because your result shows there is a gap of 5 to 6 years if you compare to the scheduled caste and the higher caste. So the recommendation from your side, there has to be a strongly recommendation from your side that the old age, the line of 60 and above should be reduced to the 50 or 55 for this group of people. Thank you.
Thank you, Dr. Lakhan, for that interesting comment. The gap is actually 3 years between SC and upper caste, and it reduces across other, which is ST, ST, OBC, etc. Actually, this calculation is based on a new paper that was actually released by, published by University of Pennsylvania team by Dr. Sangeeta, Dr. Ashish Gupta, and it is actually sad that we don't have in India life expectancy by social groups. So the sample registration system is the one that gives us answers to life expectancy related data, and the life expectancy is always dissected into state level and rural urban levels. But it's based on the NFHS, it's NFHS data plus some stimulation based on University of Pennsylvania's team, that this result has been generated for the big and major states in India. And it's from that results that I have generated this this analysis. But I completely agree with you, and that policies based on old age should be differential across social groups. I don't know about 5 and 6 years, but it is definitely definitely the age at which the old age threshold seems to be much earlier for the vulnerable population or the social groups within the rural India, and thus the policies should be sensitive, that they should be sensitive of moving beyond the fixed old age threshold of 60 definitely for the new vulnerable caste within the rural Indian community. But I also recommend, if it is in my hand, that we should also have more data that are looking much closely at both life expectancy at different ages for different for different caste groups. So I second you in your point.
Thank you so much. Thank you, sir. Thank you.
Thank you, Dr. Arun, for addressing the question. We have one question from Minit. Can you please unmute? Minit Pasa, can you please unmute?
A very good morning to everyone. Actually, I don't have a question, but just suggestions. And if we have a look at the healthcare system in India, if we really have to bring about improvement, I think so. Health literacy and awareness is really the need of the hour. And in order for it to really happen, we need to talk of the 4 A's, that is the affordability, the accessibility, the availability, and the acceptability of healthcare. What kind of healthcare system is accepted by the people, and what kind of healthcare system is available in a particular village? Because we see that people really lack the infant mortality rate, or the maternal mortality rate is due to people not having an institutionalized. So it's really important that we work on to improve on the health literacy and the awareness level on the importance of the health of an individual, be it any age group, be it the infant or the young population or the old age, where we cannot neglect any age group. So in that way, we can really bring about an improvement, be it on the maternal mortality or infant mortality rate in reducing their impact, and to really bridge a gap, people have to, so that
Thank you so much, Minit. Thank you for your comment. It's well noted. Thank you so much. Is there any other question for our panelists?
No, I think so. It's a very detailed
Minit.
analysis from their part. Thank you.
Yeah, Dr. Brandon, would you please unmute yourself? Dr. Anita Brandon, would you please unmute yourself? Dr. Brandon.
Am I audible now?
Yeah, you're audible.
Yeah. At the outset, I would like to congratulate all the 3 panelists for today who have thrown up immense learning and very valuable research findings with us. And we covered the entire gamut of ranging from old age care issues to addressing malnutrition issues and addressing comprehensive health care for all. So I have to look at my notes and raise some queries. So the one from the first speaker, Mr. Arun, I would like to flag that you mentioned that in India, rural population is aging faster than the urban, and we have to focus more on the health insurance and pension spending on the part of the government. Well, that point is well taken, although you said that the life expectancy has moved. What was earlier the old age was at benchmark 55 is now at 65, and 15 more years to live. Whereas in this context, you flagged the indicators in terms of SC, ST minorities, category is aging faster than the dominant caste groups. But what I found missing was any reference to the gender differentials in terms of aging and how women are affected in old age compared to men. So that was one. From the second speaker, I was intrigued by his very enlightening global burden of disease map, But what I noticed, to the best of my knowledge, you were showing India as green, which you said is less troublesome. But then you went on to say that stroke is the third largest killer of adults in India, whereas the global burden of disease map was showing India as green and problem-free. So I couldn't really correlate the two observations, one coming visually from the map where India is green, and when then you flag in your eye-catching, mind-boggling statement that stroke is the third largest killer of adults in India. Again, I would say that while you have talked of wasting and stunting, and you mentioned that with NRHM, chronic undernutrition has declined, but again, increased undernutrition in focus states continues. So again, I found that any kind of reference to gender differentials in terms of malnutrition, in terms of your burden of stroke as the killer of adults in India, any gender differentials were not cited at all. So I found that as a gap. And now I come to Dr. Sonu Bhaskar, who talked about all the high-tech futuristic solutions of artificial intelligence, of blockchain technology, of robotics, etc., which are all very well needed. But when we look at the digital divide of how many women have access to mobile telephones even today in rural India compared to men, it's a big question mark, the success of that futuristic solution of AI and blockchain and robotics, etc., and telemedicine. None of you, I felt, flagged the need for really focusing on, which was already a component in NRHM and continuing under NHM, which was the Ayush component. Because if you talk of health for all, and you talk not just of curative models, you talk of wellness and resilience, building resilience of people, giving their control of their own health in people's hands. So I feel this component under NRHM called Ayush, Ayurveda, Yoga, Unani, Siddha, and Homeopathy was very important, which has not really been tapped fully as a potential for giving people the control of their own healthcare and well-being. Because health for all essentially means well-being for all, not just curative services. And I also feel when you flag the need for, in terms of your solutions and your healthcare policy, training of health workers, I would like to add that training at the rural level has to focus on these frontline functionaries, ASHAs, ANMs, Anganwadi workers, as well as the crores of 8 crore women members in the women self-help groups that we have. That's a huge potential which is yet untapped in terms of training them for healthcare and being available to the community. So I feel that clubbing all these 3 components is essential when you formulate the new healthcare, compassionate healthcare for all. You have to focus on old age care because the old age population is rising. So you have to come up with old age homes, with old age daycare centers, with old age, pensions and insurance policies. You have to address malnutrition, and you have to address not just, as a holistic statistical aggregate, but gender differentials have to be addressed, and policies have to be gender sensitive and gender responsible. And in terms of futuristic models, of course, telemedicine is welcome. We already have telemedicine centers, but that specialist accessibility to people who are familiar with online technologies will not really alleviate and give the controls to people in terms of taking care of their health in rural areas. So I do feel we have to train these frontline health functionaries, and they did wonderful work in times of COVID. In the wake of COVID, India has witnessed that the rural side took better care than the urban, although with the least resources available. But because of the frontline functionaries and the women SHGs, they stood in better stead in terms of rising to the emergency of COVID, and better health systems were put in place in terms of ensuring their own wellness and prevention. So preventive health control, well-being for all, and looking at gender differentials across healthcare policy in all these 3 components of old age care, of malnutrition, and of healthcare I think that is very important. But I'm personally very enlightened by all the data and the rich insights that all three of you gave, and NIRDPR for this wonderful opportunity. I thank Ruchira.
Thank you so much, Dr. Brandon. That's there's a lot that you have given us to talk about right now, and let us take your questions one by one. I'm really sorry because we're losing out on time. I will not take any more questions from the audience. Dr. Brandon has taken all your share. You can talk to her later to talk about this. But let me just quickly throw in a question that was there in the chat box and which is in my mind also. This is to Dr. Bhaskar. What do you think is the possibility of alternative medicines in India? Because there are a few models that were tested, very in an isolated manner by a few hospitals of having a third model beyond, not public, not private, but maybe altruism-based models of medicine, where this absenteeism that we're talking about can be kind of build leadership in the healthcare professionals to address health needs of the remote locations out of altruism or out of a kind of a third model beyond public and private. And also this Ayush model that Dr. Brandon was talking about, not just the modern medicine, but the other kinds of medicine. Can those things bridge some of the gaps in healthcare equity that we have in India? So would you please take the questions? Maybe we'll start with Dr. Bhaskar, then move on to Apurv, and then finally to Arun. Dr. Bhaskar.
Thank you, Dr. Bhattacharya. And I want to acknowledge Dr. Brandon's comment about gender disparity. I think it's a huge issue, and we must always, in policy perspective, think about the gender disparity, but also the underprivileged communities in India. So that's point well taken, Dr. Brandon. Now, with regards to your comment about that, the digital ecosystem is not supported on the ground level, as well as the community healthcare workers are there, but much of the technology is not around digital literacy. Must I also remind the audience that India is one of the leading the world in terms of digital ecosystem. We produce one of the highest number of unicorns after Israel. India's ecosystems of disruptive economy and startups is changing. The world is looking at digital health and otherwise. We need to believe in our potential to really innovate. India is at the crux of doing some amazing things, and we need to, that leveraging, opening that ecosystem to startups to really disrupt the economy in rural healthcare is an important policy indication also, not just for the government, for the governments to facilitate a bit of infrastructure building, supporting literacy among healthcare workers and also to the community. But also the government needs to open up the digital sector to startups, the social enterprises, so they can chip in. India has a great potential to help in that particular and leveraging its own resources. So that's one comment that I wanted to make. Second, I think much of our focus is always about deficiencies in India. And India there's a part of India which is aspirational. We need to tap on that aspirational element of India. And through that aspiration, leveraging technologies from Indian Institute of Technologies, our IIMs, which builds on these platforms, using their expertise to build the sustainable future, could be another prerogative. I think we are not leveraging some of our own talent pool for that matter. With regards to Dr. Bhattacharya's question about using alternative medicine, absolutely, Dr. Bhattacharya, there is an emerging evidence that we need to look at, beyond traditional medicine, beyond traditional Western medicine. Yoga as an intervention, so on and so forth, is really gaining a lot of capital. In that particular tangent, I want to kind of inform the audience about a model that is now become very topical in UK, and many of the hospitals in UK are now in kind of integrating that particular model in their GP practices. It's called social prescribing. So it's being used for dementia patients, it's aging patients, and what patients are being appropriate beyond conventional medical model, appropriate services that these patients can improve the quality of life of these patients. Gardening, for example, visiting park, having tea, coffee, or practicing yoga, meditation, so on and so forth. And it's being integrated in NHS, National Health Services, under that broader umbrella of social prescribing. I believe the social prescribing is a frugal solution, an innovative solution that has a huge implications for India. A country where in rural India, where there's shortage of resources, building on our social prescribing techniques can have huge benefits to our population. If I missed anything else, Dr. Bhattacharya, please remind me.
I believe not. I think the comment on the gender differences, you have noted it. So let us move on to our next speaker, Apurv. Before you address Dr. Brandon's questions, Apurv, I have a question of my own because you are working on nutrition. I would like to know that in your model, in your calculations, did you have any kind of analysis with the food systems where these populations are? I mean, what kind of changes do you think would food systems and the nutrient intake or the dietary intake would have on the results that you are showing? And you may please also address Dr. Brandon's question, please.
Yeah, Ruchira, let me start by addressing your question first, and then I'll try to my best, Dr. Brandon, to remember all of your very thoughtful questions. If I forget any, please interrupt me. So in terms of the analysis we did, especially for the predictive modeling for estimating risk of child undernutrition, we did not account for availability of public health programs because it's a bit of a circular discussion in terms of thinking about more digital programs and interventions that could potentially intervene on the risk at the time of delivery. For in terms of the impact of National Rural Health Mission, um, given the heterogeneity of the availability of those programs, we made some broad assumptions to be able to uh, estimate the impact of National Rural Health Mission. But we have in one of the book chapters that we wrote with Zulfikar Bhutta and Dr. Menon, we looked at more in-depth analysis of different availability of the public health programs uh, instituted under National Rural Health Mission, also under National Health Mission, and how that impacted child undernutrition rates. So not quite in the data that I presented, but in some of the other work, we touch upon it. Um, I think the bigger challenge from our perspective that we would submit is it's not that there is a lack of resources. It's more that there needs to be a matchmaking of resources connecting to the right people and to the right population, especially if we have a lens towards reducing disparities. And I'll use that to kind of piggyback on the very important topic of considering gender-based analysis. So part of the data that we did not show is highlighting how much of an impact um, there is in terms of gender-based disparities, but also what protective impact increasing maternal education or even increasing female education in a household, especially in the context of joint households in rural settings, has on preventing undernutrition, but also preventing uh, outcomes of undernutrition later on in life. So we have a paper that we published in PLOS Medicine that looks at the protective effect of maternal education, and you really can't talk about child undernutrition without acknowledging the intergenerational impact of gender disparities and gender discrimination that perpetuates a lot of the undernutrition. That said, I think we need to start somewhere, and starting with part of the predictive model actually accounts for some of those disparities and increases the weight of a or kind of increases the probability of a female child being undernourished. So it's not I didn't specifically call that out, Dr. Brandon, but that's very much heavy on our mind. Uh, in terms of the question related to the possible discordance between the map that I showed on the global burden of disease versus the statistics about stroke being the largest killer. The map was in fact of atrial fibrillation, the arrhythmia that is highly associated with stroke, and that the point that I was trying to raise there is atrial fibrillation, which is most commonly detected by a electrocardiogram. The global burden of disease map showed a disparity that was actually based on health systems as opposed to actual biological risk. And kind of contrasting that with stroke being such a high prevalence in India, where the atrial fibrillation which is among the most leading common causes of stroke. If that's underdiagnosed, that's more of a surveillance problem, because we see the sequelae of atrial fibrillation being very high. So I hope that covers most of the questions that were directed to me. Dr. Brandon, if I missed anything, either you or Ruchira, you can come back to me, but I want to be mindful of Arun's time in responding to the questions.
Thank you, Apurv. I believe you have addressed most of the queries, and I do know that you have other papers and other analysis that you have where you have addressed gender, and I will share it with our participants who are here and in some time. Arun, would you like to address Dr. Brandon's comment, and then we can formally close the session? We are already like 15 minutes ahead of our time.
Sure. Thank you. I'm glad that Dr. Brandon, you asked this question. In fact, my recent paper on in Aging and Society exactly addresses this question about gender differences in aging. Just to pitch on a main result from there is that if you look at from the life expectancy based approach, actually females old age threshold is higher than males, which means female get older at a later age than males. However, if you add this additional perspectives of disability, cognition, and health into it, this pattern almost nullifies or sometimes even goes is biased against females. So that means the female life expectancy is generally very higher. However, the health adjusted or the disability adjusted life years is lower, and thus poses a much bigger challenge in older ages. So thank you for your question, and thank you for the session.
Thank you, Arun. And with that, let me formally conclude the program today. I'm really grateful to Dr. Sonu Bhaskar, Dr. Apurv Soni, and Dr. Arun Balachandran for patiently being here with us. And I know you are from different time zones. It's very late where Apurv and Arun are, and it's probably midday where Dr. Bhaskar maybe late in the day where Dr. Bhaskar is currently situated, but they have still stayed with us and have shared their presentations and answered our questions. So with that, let me conclude the 9th webinar of the Evidence-Based Policy and Roundtable series. To our presenters, we would like to tell you that these presentations that we are making, this is the 9th one, there were 8 more before that. These are basically to kind of formulate a rural development policy handbook later. In the future. So once that handbook is in the process, we will again reach out to you for a little less technical and more policy oriented inputs to formulate the rural development policy. And I hope that you will be joining us in the future programs as well. And in terms of telemedicine, the government of India is doing a lot of work to bring in telemedicine in rural India especially. And we are having a lot of discussions on how to kind of make it feasible, what are the kind of infrastructure that will require, what are the kind of manpower requirements that there probably might be, and all those discussions are there, and maybe we will reach out to you for further discussions on these digital solutions, the technological solutions. Dr. Apurv, I see your hand raised. You have a comment on this?
Yeah, Ruchira, I don't want to prolong the session too much, but I just want to put a plug in. Part of, and I'm not sure if telemedicine is covering acute care or inpatient level of care, but one of the things that I've been leading and our group has been leading is developing hospital at home programs in US, which obviously has its own regulatory challenges, but I wanted to just put a pin on that for future conversations.
We will explore that definitely. And I also thank all the participants who are here and have been patiently listening to our presenters. Dr. Brandon for joining us and enriching the discussion as always. And to NIRDPR for hosting this program and helping us get this platform out. And with that, let me thank you and let us meet in the next webinar. And until then, good night to our friends from US and very good evening to our friends from Australia, and good day to all of you. Thank you.
Great meeting, Dr. Bhattacharya.
Thank you.